Atrial septal defect. ASDs are commonly encountered and occur in one third of adults with congenital heart disease. Various types exist, but secondum ASD present in the area of the fossa ovalis is the most common, accounting for 75% of defects. Ostium primum defects associated with endocardial cushion defects and inlet type VSDs occur in 20% of cases. Sinus venosus defects, usually superiorly located, occur in 5% of patients. The rarest type is unroofed coronary sinus. Associated lesions may occur and include pulmonary stenosis, VSD, mitral valve abnormalities such as regurgitation or stenosis, and syndromic problems such as Down syndrome and Holt-Oram syndrome. Most cases of ASD are sporadic, but familial cases of ASD have been reported, especially in patients with coexistent prolongation of the PR interval. Now, what is the natural history of ASD? ASD often go unrecognized for the first 2 decades because of the indolent clinical course and benign findings on physical examination. Careful inspection of the ECG usually demonstrates a characteristic RSR complex in the anterior precordial leads with a rightward QRS axis in patients with secondum type defects and left axis deviation in those with primum type ASD. Initial diagnosis in adulthood is common and survival into adulthood is the rule. However, life expectancy is not normal in unrepaired patients, with mortality increasing by 6% per year after age 40 years. Progressive symptoms of dyspnea on exertion and palpitations frequently occur in adulthood and are caused by increasing right side chamber enlargement. Pulmonary hypertension, RB failure, tricuspid regurgitation, and atrial arrhythmias. Patients with large ASDs causing left to right shunts develop RV volume overload, which is relatively well tolerated for the first 2 decades, but thereafter results in right heart failure and arrhythmias. The subsequent increase in serum BNP levels and decrease in exercise capacity are correlated with the magnitude of left to right shunting. The degree of left to right shunt may increase with age as LV compliance decreases and systemic arterial resistance increases after the 4th decade of life. Paradoxical embolism may occur but is a rare complication. The risk of infective endocarditis is low unless the patient has coexistent valvular disease, example cleft mitral valve. Now, this diagram showing various types of ventricular septal defects, ASD and various types of atrial and ventricular septal defects. The heart is viewed from a right anterior oblique projection, and the right ventricular and right atrial free walls have been removed. 1 shows secondum type ASD, 2 is primum type ASD, 3 is superior sinus venosus ASD, 4 is inferior sinus venosus ASD, 5 is coronary sinus ASD, 6 is perimembranous VSD, 7 muscular VSD, and 8 inlet VSD. Now, what is the ECG shows here? Here, figure A showing a 12-lead ECG of a 30-year-old woman with a large secondum type atrial septal defect. Here, 42 mm in diameter by transesophageal echo and moderate pulmonary artery hypertension. Note the right axis deviation and tall precordial R waves consistent with right ventricular enlargement or hypertrophy. There is evidence of right atrial abnormality. In ECG B, a 33 years old man with a primum type ASD surgically repaired at 3 years of age. Note the continued presence of a characteristic RSR complex in lead V1 and QRS left axis deviation. Now, what is the management and results of ASD? Surgical repair via direct suture of small defects and patch closure of larger defects has been performed for more than 40 years and has been efficacious and safe provided the pulmonary arterial resistance is not severely elevated. Closure of small defects that is less than 1 centimeter in asymptomatic patients diagnosed after 25 years of age is controversial, with no significant difference in clinical outcomes between medically and surgically treated patients followed for over 20 years. A retrospective study of Constantinis et al. Of 179 patients diagnosed after the age of 40 years with a QPQS ratio of 1.5:1 or greater demonstrated a relative risk of 0.31 for patients who underwent surgical closure as compared with patients treated medically. Estimated probability of survival was 95% at 10 years for surgically treated patients and 84% for patients treated medically. Predictors of increased mortality in the surgical group included older age at operation, advanced heart failure such as NYHA class 3 or 4, QPQS ratio of 2.5:1, pulmonary artery systolic pressure above 40 mm mercury, and pulmonary vascular resistance above 1.6 Wood units. Non-fatal clinical outcomes such as supraventricular arrhythmias occurred with similar frequency between the two groups. However, the operations carried out in this study did not include atrial arrhythmia surgery, Mage or Cox-Mage procedures, which is known to decrease arrhythmia recurrence in patients undergoing surgical ASD closure. A prospective randomized study by Atty et al. Of surgical versus medical management of ASD in 241 patients older than age 40 years did not demonstrate similar survival advantages over 7 years of median follow-up. However, a significantly lower percentage of patients in the surgical group reached the composite endpoint of heart failure, recurrent pneumonia, peripheral or pulmonary embolism, or death, leading the authors to conclude that surgical closure should be performed in all patients with an ASD and pulmonary artery systolic pressure below 70 mm mercury and QPQS ratio above 1.6:1. Pulmonary artery vasodilator therapy with prostaglandins, endothelin blockers, and phosphodiesterase 5 inhibitors may reduce pulmonary arterial pressure and resistance to a level that allows consideration of shunt closure in these patients. But this should only be considered at centers experienced in the management of such patients. Current ACC AHA guidelines recommend consideration of closure if pulmonary artery pressure is less than two-thirds of systemic level, pulmonary vascular resistance is less than two-thirds systemic vascular resistance, or there is a positive response to either pulmonary vasodilator therapy or test occlusion of the defect. Pulmonary vasoreactivity testing and the trial of pulmonary vasodilators for several months may help risk stratify patients with borderline pulmonary pressures for closure. In a study by Balint et al., many patients with ASDs and pulmonary arterial hypertension continued to have elevated pulmonary artery pressures after closure, and 15% had persistent severe pulmonary hypertension. Closure is contraindicated in patients with severe, irreversible pulmonary arterial hypertension and no evidence of left to right shunt. Severe pulmonary hypertension in adults with ASD usually represents the coincidence of idiopathic pulmonary hypertension or pulmonary hypertension secondary to another process, example scleroderma. And ASD, unlike patients with large unoperated non-restrictive central shunts, example VSD, who experience pulmonary hypertension from birth and develop pulmonary vascular disease within the first few years. Patients with large ASDs of similar shunt magnitude do not necessarily develop severe pulmonary hypertension, and right to left shunting or the onset of pulmonary hypertension is delayed into late adulthood. However, a large ASD may well contribute to the development of pulmonary hypertension but may not be the sole cause of the underlying pulmonary vascular disease in a cyanotic patient. Patients with trisomy 21, that is Down syndrome, may develop accelerated pulmonary vascular disease in the presence of ASD, primum or secondum. Now, transcatheter device closure of secondum type ASD was first performed in 1976 by Mills and King. Advancement in device design and catheterization technology have led to the availability of a variety of occlusion devices. Transcatheter device closure compares favorably with surgical closure in terms of efficacy and is associated with shorter hospital stays and fewer post-procedural complications. Appropriate patient selection is imperative, may be accomplished by a variety of non-invasive and invasive imaging methods. Transcatheter device closure techniques have supplanted surgery at many institutions as the method of choice for ASD closure in properly selected patients. Complications are rare. Short-term complications have included device embolization, aortic root or atrial wall perforation, and cardiac tamponade. Mid and long-term complications include thrombus formation, device erosion into the aortic root, atrial dysarrhythmias, and infective endocarditis. The use of platelet inhibitors for at least 6 months after device closure is recommended to decrease the risk of device thrombosis. The long-term outcomes of device closure using the Amplarger septal occluder are excellent, as evidenced by no deaths and minimal complications of 151 patients followed for 6.5 years after ASD closure. Thank you.